Yeah, so feel free to make your comments on the chat. So somebody's already got it, even without even any any introduction. So we got a shave biopsy. So somebody said poro, which is right, but there's about 5 or 6 types of poro. So which type would this be? Yeah, probably DSAP. Now somebody said Mabelli, but this is pretty small for Mabelli. It's a little small lesion, and you can see 2 cornered lamellae here. And Mabelli is a larger lesion, and also notices on severely sun-damaged skin. So that would fit better with DSAP. Again, we know these are widespread lesions. They're often clinically missed. People think they're things like a basal cell or actinic keratosis or whatnot. Notice the cornered lamella kind of curves centrally into the middle of this lesion. And there, who knows what the recent genetic abnormality that's been associated with poro. That's something that the board might ask you. So this is so simple, they would expect a first week resident, if they were taught what this was, to be able to get this right, because it's got this classic column of porokeratosis with the dyskeratosis at the base. This is a classic cornered lamella. I believe it was a fumarate hydratase deficiency. There was recently an article about a year ago in JAD or JAMA Dermatology, I believe, where they actually looked at poro and found that it's actually an enzyme deficiency that causes this problem. So it's kind of interesting that now they actually know what's the cause of it. So I could be wrong with the enzyme. I'm just going off my memory from reading the article a while back. But I would recommend that you learn that, because whenever dermatology gets some kind of a gene associated with it that explains a disease like a calcium transport process or keratin gene mutation, whatever, you can pretty much expect that to be on the exam somewhere. So now that this is on there, they're going to probably ask you. And this would be DSAP as opposed to Mabelli and those kind of things. These are some of the other types of poro. This would be more of the Mabelli type probably. This might be a DSAP-like lesion. I don't know if you know what this type would be. If anybody knows, write that down. And this would be more of a linear poro. That's actually sometimes like an epidermal nevus. Yeah, Tychotropica. And anybody know what the PTYCHO part means? It's got a specific reason that they named it that. It wasn't just because they thought it sounded kind of cool. It means wing, like pterodactyl, like from Jurassic Park. The PTY part refers to wing, and that kind of looks like 2 wings that are kind of flapping together, because it usually occurs in the buttock area. So anyway, well, I got another picture of that to show you. So just make sure that you know the various types of poro also. They all are pretty similar. Sometimes you can get lichen inflammation in the center of the poro. You sometimes see squamous cell carcinoma in situ in the center of the poro. Not often, but happens sometimes. This would be the Tychotropica once again. If you biopsy this, it gives you this really marked verrucous appearance. It doesn't have that thin epidermis like we see in the center of a Mabelli or DSAP. It gives you these marked verrucous columns of cornoid lamella. It almost looks a little bit like an Ilven in a way. So it may actually be kind of almost like an epidermal nevus in some way. Here's another example of that. So just remember, that's the tychotropic form of poro, which occurs in the buttock area. Okay, shave biopsy in this case. And we've got some porokeratosis and some crust, and then something going on down here in the dermis. So we've got some epithelial hyperplasia, but it doesn't look like a neoplasm. And then at low power, we've got these pale cells. Pale cells. So obviously, what do we think of when we think of pale cells in the dermis? It might be inflammatory process. I think it might be sort of an infectious process, granulomatous inflammation. And here we've got neutrophils. So we've got suppurative granulomatous inflammation. So whenever you see that, instantly think of infectious diseases. Suppurative granulomatous dermatitis with overlying epidermal hyperplasia, think infection. Someone put pheohyphomycosis. Careful on that, because pheohypho generally is associated with non-pigmented organisms. But here we've got some dark pigmented organisms. Yes, copper pennies. Now, where do you look if you want to find organisms? Where's the best place to look? Well, the best place is if you see suppuration. You see like an abscess or neutrophils, look there, because you'll get an infection on the exam too, for sure. So if you want to kind of do a more efficient bug hunt, look in the separative foci, look inside the cytoplasm of histiocytes, and then also you want to look if there's any overlying crust, because the organisms often get transepidermally eliminated through those little channels. That pseudoepithelial hyperplasia is one of the ways that the host deals with these infections. So here you got some copper pennies up in the cornified layer, in the crusted area. So what are the copper pennies? What are they actually doing? Well, they're actually little, what we call sclerotic bodies or medlar bodies, named after Dr. Medlar. And these actually, the way these organisms sort of grow in your skin is they usually don't make hyphae. They usually undergo this binary fission process. See the little cell wall between the two little areas here? So that's a nice example of the way that these organisms slowly multiply in your skin. So they're not generally germinating and forming hyphal elements. So that's why it's not really called hyphomycosis, because there's no hyphae. If they are hyphae, it's really unusual. A person's usually got no immune response in that situation. But in Chromoblastomycosis, generally you don't have the hyphal elements. So here you've got a clinical picture, classic appearance, crusting, verrucous hyperplasia, all the pseudocarcinoma hyperplasia that we see. So one thing that you probably, if you want to get a couple extra points on the exam, learn a bit about like some of the dermatiaceous fungal organisms. And I'll talk a little bit about that here. So these are some of the causes. These are dermatiaceous pigmented organisms. And these are the ones that cause it. Fonsecaia pedrosoi or compacta, cladosporium, carianii, Phyllophora verrucosa, rhinocladia, used to be cladosporidium. So these are all the different organisms that cause this condition. Okay, and this is kind of what they look like in a phase contrast microscopic view here. Okay, now mycetoma is a little bit different. Here you're dealing with grains as opposed to medlar bodies. So just for review, here you see a grain here. This is a grain of actinomycosis. And again, these are gram-positive filamentous organisms. So there's a grain there. A red grain, anybody know what that's caused by? Actinomadura pelletieri. So that's the red grain. Good. Somebody knew that. That's excellent. Brown grains, seen with the eumycotic mycetomas. Madurella is the common cause of that. And so this looks like a little amphora, kind of like a little vase, like a Phyllophora or Exophylla janselmi would look like that growing in culture. And these give you these yellow-brown hyphal elements. These little septate hyphae branching in culture that are pigmented like you see here. And here's one that's got more clear. These give you pale grain, pseudo-Alischeria boydii. So remember, grains in tissue, actinomadura pelletieri, it's the only one that causes a red grain, so they might ask that. You know, if Ted Rosen writes any question for the boards, he'll probably put something like that on there because he loves organisms. Black grains, always eumycotic. So just make sure you know a little bit about these if you want to get an extra point or two on the exam. They probably won't have a lot about that on the exam, but it's easy, probably better than memorizing some obscure gene. So, you know, not a bad idea to maybe just learn a little bit about that. Okay, punch biopsy this time, and we have at low magnification holes. Now, how do you know if their holes are real or false? So, you know, you see holes, you say, well, gosh, maybe it's just lousy lab processing. They got these artifacts. You know, that may be an artifact down here, but you got a lot of spaces over here. So when you see something like that, you want to ask yourself if it's real or not real. So we've got a higher magnification. We're looking to see if there's a lining in those little clear spaces there. So if there's some lining to those spaces, that means it's a real thing. It's not fake. And here we got a lot of these spaces. They vary in size and shape. There are some cells lining them. Go to higher magnification over here. You can also see that they have kind of an unusual morphology that kind of looks almost like a staghorn or antler-like morphology. And they're lined by these darkly staining hyperchromatic cells here that protrude into the lumen. And in some areas, they actually are floating freely in the lumen. Anybody know what the diagnosis is here? I pretty much told you the criteria for the diagnosis. And we have a punch biopsy out of a sea of vascular spaces. So again, so forget about asymmetry, poor circulation, all those kind of things are gone. Can't tell anything. So somebody said hemangiopericytoma, but what about just an angiosarcoma? Yeah, angiosarcoma. Hemangiopericytomas are very, very cellular lesions. And they give you some irregular vascular spaces, but they often have, we also talk about those as being myopericytoma and hemangiopericytoma. We've got these myocytic areas. They almost look like myofibroma plus vascular areas. So those are usually more solid. This is more diffuse, open vascular spaces that are irregular. And whenever you hear the term staghorn, antler-shaped, dissecting vascular spaces throughout the collagen bundles, large atypical endothelial cells protruding into the lumen and floating freely in the lumen, angiosarcoma. Angiosarcomas can be several different variants of these. There can be a very well-differentiated angiosarcoma that doesn't even look malignant. There can be a poorly differentiated angiosarcoma that's comprised almost wholly of the endothelial cells, and sometimes those can be spindle, and they look like other spindle cell neoplasms. And then there's an epithelioid angiosarcoma that can look like a squamous cell carcinoma. So whenever you see this diffuse pattern dissecting irregular vessels like that, think of angiosarcomas. And there's several different clinical variants. The most common is probably this type on the scalp of older individuals. The trunk, especially women that have had breast cancer, people that have swollen extremities, lymphedema, people in Africa, they get filariasis, get swollen legs, they get angiosarcoma. So a lot of different ways to get that. Whenever your blood flow can't get out of your extremities, you can develop an angiosarcoma. So Stewart-Treves angiosarcoma, and then sometimes following radiation therapy. So anyway, this was a classic example of that. Hopefully everybody got this. And various stains can be used. The newest one is ERG, that stains blood vessels quite nicely. Differential diagnosis, Kaposi sarcoma is more of a spindle cell process without the large staghorn blood vessels with the freely floating endothelial cells in there. So that would be, that actually wouldn't be unfair to put KS and something like this down on the differential, because this doesn't look anything like Kaposi sarcoma. So just make sure that you understand that. It doesn't look anything like a pyogenic granuloma. It doesn't look anything like a metastatic renal cell carcinoma. Those are all vascular lesions, but none of them give this diffuse staghorn-like vessels with the endothelial cells that are atypical floating freely in the vascular spaces. An atypical vascular lesion on the breast, you're not going to need to know that. So the answer is no one can tell that apart clinically. A lot of times we excise those, we follow those patients, they may be incipient angiosarcoma. So don't worry about that. That's way over your head for the board exam. Okay. Shave biopsy, dome-shaped papular lesion, and it's got a spindle cell morphology to it. Okay, looks like it's fairly symmetrical. It's pretty well circumscribed. It goes to the base, but based on what we have here, we think it's probably a little round bump in the skin. And higher magnification, so these cells have kind of a epithelioid morphology. They're arranged in these little aggregations. Okay, we go to higher magnification. They look like they're little small nests, and they're also these collagen aggregations, these sort of, it's got almost kind of a trabecular pattern. These struts of collagen between the aggregations that are growing in these nests and cords and strands that have coalesced here. So it's not that got these little round nests that we classically see with a nevus, but it could be a nevus. But it's an epithelioid process. So there's a differential diagnosis here. So you say, well, maybe it's something like maybe these could be epithelioid histiocytes. Maybe they could be epithelioid melanocytes. Maybe they could be epithelioid endothelial cells. So they could be a number of different entities. And it looks pretty much benign. Most of these cells are typical in their appearance. The lesion's got an architecture of a benign process. Occasionally on these lesions, you might see a mitotic figure or two, but this looks pretty bland and pretty banal cytologically here. No pleomorphism, so we favor benign. So this is one that you wouldn't get on the exam without some more information. So I don't know if anybody knew what this was. This is what the lesion looked like clinically. So if you just came, and sometimes we give unknowns when we're doing this exercise that don't necessarily have a right answer or have an answer that you can get. And that's troubling to residents and to students because they always want to get a definitive right answer that they can sort of plant the stake in and know the answer. But in a case like this, you have to live and be uncomfortable with uncertainty a little bit. So we don't know here. We favor benign. It's epithelioid. We're going to work it up more. So maybe they might give you some immunoperoxidase stains of choice and tell you this stain was, for this lesion stained positively with CD63 parenthesis NKIC3 and negative with S100 protein and CD68. What's the most likely diagnosis? Well, they might not say CD68 because that sometimes is positive here, but they might say what's the most likely diagnosis? And you may or may not know the answer, but what this is a cellular neurothekeoma. Good, someone did know the answer. And there's two types of neurothekeoma. There's the more classic nerve sheath myxoma variant, where you get a lot of mucin, spindle cells, and then you get this type. And we didn't know when I was training back in the days before we had many immunoperoxidase stains, we didn't know what this was. We thought it might be related to muscle. So no one knew what this was for years. But finally, when they started figuring out that it's got this CD63 or NKIC3, it's S1 protein negative, it's probably somehow related to a nerve sheath, but it's not actually like a myxoid nerve sheath lesion. So it's still a little bit controversial exactly what the origin is of this thing, but this is the classic staining pattern, and that's what these things look like histologically and clinically. So hopefully you guys were able to come up with that. It looks like a couple of you did. Okay. This one, more straightforward. This one they very well could ask you on the board, and they might actually show this to you and ask some second order questions. So punch biopsy, it's a neoplastic process. It's non-epithelial. You should see that pretty well quickly at low magnification. And you can say, well, it's got these little aggregations of these structures here that got these little clefts surrounding them, and then some areas that kind of coalesce. Goes down to the bottom. They're pink. It's kind of a bubble gum color to it at low magnification. Or higher magnification, again, spindle cells arranged in these fascicles that are kind of coalescing. Individual cells have some of these periapical vacuoles here. The cells are not strikingly atypical. Good, someone has put the diagnosis, which is correct, of Pilar leiomyoma. So this is straightforward. Board might put this on there, and then they might even show you some codochromes of this and say, okay, the syndrome that's most commonly, or that one has to be concerned about associated with this entity is Reed syndrome. Good, you all know what that is. So that's great. So this is review for many of you, for maybe younger residents, first years or whatever. It might be new information, but for the third years, hopefully you got this pretty well without any concern. So this is a classic pilar leiomyoma, and you have to worry about Reed syndrome. Now they would obviously ask you what the syndrome is associated with. What are some of the things that we get concerned about there, right? That fumarate hydratase deficiency, which someone, if you've got access to your internet, you can check on the Poro and see if it's the same enzyme. It may be a little different enzyme there, but the Poro definitely has an enzyme deficiency associated with it. And notice the classic clinical picture here. They're almost agminated lesions very commonly. They're seen to cluster, like a cluster of sheep. They're grazing on their grass here, but they're not tightly grouped like a herpes type lesion. We call this agminated configuration here. These are often basically painful. So this is one of our painful lesions. And again, these are associated with renal cell carcinoma, as someone put up there, so that's important to know. Is the renal cell carcinoma here the clear cell renal type or the papillary renal cell type that's associated with, is it a more serious cancer or a less serious cancer that's associated with this? So if you get a renal cell carcinoma that happens just basically at random, or one associated with this, is it tends to be more aggressive or less aggressive? That's a question that might be of interest to know. And someone asked the question, can you tell us the difference between angio and pilar? Yes, you should be able to tell the differentiation between those two. An angio is a round nodule in the skin that's well circumscribed, and it usually comes in as a cyst. These lesions are more diffuse. So yes, you should be able to tell these apart from one another. As a general rule, when cancers develop in a syndrome, or they develop a germline cancer, there's a germline mutation that leads to a cancer, tends to be less aggressive than a cancer that develops later from a couple of mutations that develop. So some of the types of cancers that develop in childhood, for example, or their germline mutations, they tend to be less aggressive than the same cancer that develops later. So if you get a renal cell carcinoma later in life, that tends to be worse than if you've got a renal cell carcinoma that's associated with Reed syndrome, just as a general rule of thumb. Not always, but that's a good general rule of thumb. So this is a pretty straightforward one. Hopefully you all got that right. And a fairly simple example. Okay, this was a good case because it shows a reaction pattern that should throw you down into a differential diagnostic category that you need to know for sure. So what's the reaction pattern here that we're testing on here? It's a shave biopsy. Sadly enough, it would have been nice to get a punch biopsy. I don't know if any of you could tell what part of the body it's on. Okay, subcorneal pustule, you're close. You're in the right category. But there may not even be a cornified layer here. If there is, it's, you know, kind of hard to tell. Yes, good, it's mucous membrane. There's no follicles here. And this really isn't a cornified layer, so to speak. It's kind of like the upper part of the epithelium that's still got a few, it's basically kind of got nuclei all the way through. It's not really forming a cornified layer. So what's the other pattern if it's not really a cornified layer? What do we call it? You're close, but it's not exactly subcorneal pustule. So if some mucous membrane, it can't be subcorneal. There's no cornified layer there. So what do we call this pattern? We call it intraepidermal pustule formation, a spongiform pustule formation. So intraepidermal neutrophils, okay? It's similar to subcorneal, but slightly different. So what diseases do you see neutrophils in this forming almost an abscess within the epithelium? So what are some of the conditions where you see that spongiform pustular intraepidermal formation here like this? What are some diseases where you see that? So you should obviously think of a few because the board's going to ask you this. They might say, they show you this, say, what's the stain that you might want to do here to make a definitive diagnosis? You would definitely look for fungus. So you could say tinea, but if it's mucous membrane, it's more likely to be tinea. Or what else would be the more likely cause? Mucous membrane. Candida, good. And psoriasis, excellent. Pustular psoriasis and all of the fruits of the poisonous psoriasis tree, if you will. Everything that goes along with that. Von Zumbusch pustular psoriasis, AGEP, pustular drug eruptions, all those things are related to one another. So when you think about reaction patterns, throw them in there together. Yeah, you can throw in Sneddon-Wilkinson, IgA pemphigus, which to me is this. I've never really seen a case of well-defined acantholysis with IgA in there in 30 years of practice. So I think it's probably really more likely this with IgA than really truly pemphigus. And so what if it's on the mucous membrane? What else do you think about? You got everything right, but what if it's on the mucous membrane? You call it pustular psoriasis there. You call it Sneddon-Wilkinson there. What do you call it? What if it's on the tongue? What do you call it? What do you call this? Geographic tongue. Excellent. Which if you biopsy it, it looks just like pustular psoriasis. So basically, it is psoriasis on the mucous membrane. That's the way I think about it. So when you get that kind of reaction pattern, think about that. One other one to think about is, I guess they're calling it pustular psoriasis on acral sites with arthritis now instead of Reiter, who was a Nazi. So we don't like to use his term. So the disease formerly known as Reiter's disease also gives you the same pattern. And it can develop in a lot of different settings, HIV disease and other situations there. So just remember spongiform pustular eruption, fungus, infectious, sometimes bacteria, less commonly, and then all the psoriasis, pustular psoriasis family of disease there. Okay, excellent. So these are some of the other conditions. Acrodermatitis continuum halibut. We can still use his name. Sometimes you just get one lesion, one nail with psoriasis. Okay. All right. Shaved biopsy. Got an infiltrate of darkly staining cells in the dermis in a band-like fashion down here. Go to higher magnification. We've got some dilated blood vessels. We've got some extravasated erythrocytes. Okay, so inflammatory process, band-like infiltrate, kind of lichenoid. What part of the body are we on? Okay, somebody said lichenoid PPD. What part of the body are we on? The answer is staring you right there in the face. Good. What part of the leg? And why? The lower leg, because these are stasis-altered blood vessels. Good. Thick-walled blood vessels, more than normally you should see. Maybe okay in that area. It's almost normal there. This is a little bit out of the range of normal. Yeah, and this is a lichenoid persistent pigmented purpuric dermatitis. Excellent. That's exactly what this is. And a lichen aureus is basically the same process that for the inflammation goes away and it gets just more siderophages. So again, this is a family of diseases as well. There's about 5 of these that are associated obviously with Schamberg's, lichenoid purpura of Gougeron bloom, zymatid purpura of Ducas and Capitonochus, the annular persistent pigmented purpuric dermatitis of Miyake. So those are the types of PPPD that we can see. So basically just all different variants of the same process. And most of them occur on the lower legs, but you can get them anywhere on the body. The Ducas capitonochus are widespread over large parts of the body. You can get the Miyake's can occur anywhere in the body. So basically just remember that these aren't confined to older men in the lower legs. They can be seen in a lot of different settings. So we see it in kids as well sometimes. So that's an example of one of the persistent pigmented purpuric processes with a lichenoid infiltrate. Good. Okay. Different situation here. We've got probably an incisional biopsy. This isn't a shave biopsy, probably an incision of something. They might have even tried to enucleate this. And where are we on the body? What are we looking at here? So what's this material that we're looking at? Cartilage. Good. It could be the ear. Excellent. Could be the ear. Is this the type of cartilage that you get in your knee, for example? Not really. It's basically hyaline cartilage, and its hyaline cartilage is kind of present sort of diffusely here. You don't have fibrous change and bone underneath this with a rim of it on the top like you see with fibrocartilage that's seen in association with our bones and whatever. So this is hyaline cartilage. And it is on the ear in this case, but you could see it on the nose or, a few other places where we sometimes interface cartilage and the skin. And is this normal cartilage? Is this normal? So if we took a punch biopsy out of your ear, yeah, it is dying. And where is the death occurring? So is it occurring out here at the periphery, or is it occurring in the center here? Center. Yeah, in the center, it's dying there. Yeah, this is not normal here. There's no residual live chondrocytes here in the center of this thing. this is all turned to a purplish, mushy goo. So the cartilage is made of hyaluronic acid is now liquefied here. Liquefied here. Now, somebody put a relapsing polychondritis. I would encourage you not to just pull a gun out and fire, but to know your criteria for the diagnosis and then apply the criteria. So know these things. So relapsing polychondritis requires inflammation occurring at the periphery of the cartilage, destroying the cartilage at the periphery and replacing it with fibrous tissue. Okay, so that's what you need for the diagnosis of relapsing polychondritis. Chondrodermatitis requires a superficial erosion and ulceration with inflammation and fibrous tissue at the surface with degeneration of the cartilage at the very top of the cartilage only with fibrosis surrounding it and pseudoepitheliomatous hyperplasia. We see that here. No. What we see here is central ischemic necrosis of the cartilage with no inflammation in the center of the cartilage. Do we see that here? No. You're close with preauricular cyst, but you just take the pre out and put pseudo-cyst of the auricle, and you've got the right diagnosis. So this is what's going on here. Pseudo-cyst of the auricle. So relapsing polychondritis is a systemic illness where you get an autoimmune reaction to the cartilage of all over the body. Not a good situation. Patients get arthritis, they get myocardial infarction, they get blindness, they get all sorts of bad things from that because that's an autoinflammatory process. Here, no, this isn't CNH, not CNH. This is an intracartilaginous destruction of the cartilage due to chronic trauma that you see like in wrestlers, a different kind of trauma. Put somebody in a headlock and do that over and over again, or you go boxing, like the boxers get this very commonly. You hit the arm, they get trauma, you get inflammation, it goes away, and eventually the cartilage degenerates internally. There's no fibrosis here, there's no epidermal involvement. This is a deep involvement of the cartilage in the center of the cartilage. So this is not CNH, it's a different ballgame altogether. It's caused by a different type of trauma than with CNH, which is due to like talking on your phone or wearing a wimple if you're a nun, those kind of things, wearing hearing aid. That's how you get CNH. So this is degeneration of the cartilage from within. And it's not a true cyst because it's not lined by an epithelium. So it's a good name. It is a pseudo-cyst of the auricle due to long-standing ischemic necrosis of the cartilage internally. So it's a different ballgame. So just make sure you know that entity. I don't know, they probably wouldn't ask that on the exam, but they sure could. It's not unfair to ask that. Okay, we got a punch biopsy here. At low magnification, we don't see a whole lot. It's probably going to be an inflammatory process, and there's some blood vessels up here, but there's really not a lot else going on at low magnification. We've got a higher magnification. We've got an increase in these blood vessels here that still could possibly be normal. And then we look down here, got some sweat glands, kind of unimpressive so far. And now we get something that's important. So go back to low magnification. Once again, we ask what part of the body we're on. There's no many hair follicles here. There's not that many. There's a lot of these blood vessels, pituitary. So once again, maybe we're on the lower leg. So the main change are down here in the subcutaneous fat. And there's not much in the way of inflammation, but we do have this finding right here. So this is a pretty subtle biopsy. A lot of times it's a lot more impressive than what we see here, but we do see the changes here that are pathognomonic of this process. So you got a few foamy macrophages here. Yeah, this is Lipodermatosclerosis. Here is much better area on this side. This is what we like to see. Let's get some inflammation here, and you get the membranous fat necrosis of the lipocytes here. So this is the arabesque so-called appearance of that. I don't know why I call it that, but you get these are not actually lipocytes anymore. These are little fat microcysts, and you got some granulomatous inflammation because the fat cells have degenerated. The inflammation comes in here secondarily. So this isn't a primary paniculitis. This is a secondary change due to ischemia. So it's not so great to get stasis things. A lot of bad stuff with stasis. Stasis associated with vasculitis. You can get stasis ulcers. You can get stasis dermatitis. You can get this condition. So stasis, you know, is not fun to have, and it causes a lot of problems. So this is also known as sclerosing paniculitis or hypodermitis sclerodermiformis, because it's got sclerosis clinically, and histologically you can see, you know, some sclerotic collagen. It doesn't really look much like sclerodermomorphia on the microscope. You get a little bit of sclerosis, but it's not really classically like morphia histologically, and you can get some inflammation. This is all secondary, but look for the membranous fat necrosis. That's the key, and this is what it looks like clinically. Got the stasis change here. This guy's got this white cribriform pattern, so he probably had some stasis associated lividovasculitis also. And it's got the inverted Coke bottle, inverted champagne bottle appearance here. So this is a classic clinical picture of this, and if you feel this, it feels super sclerotic clinically. Okay, so hopefully you all got this right. I have seen extremely good response to this using Plavix. It works great. Better for the stasis-associated lividovasculitis, but it helps with this also. So if you want to treat a patient with a relatively innocuous drug, this works pretty well. You're not going to reverse that sclerotic collagen very well. Once they get that champagne bottle appearance, that's there for life. So you really would like to get that treated before they get those manifestations. And then obviously know the differential diagnosis of the different paniculitides that are associated with this. But when you see that membranous fat necrosis with stasis change at the top, think of this diagnosis. Okay. This one's kind of a fun little diagnosis, and sometimes the board puts something on there, they just expect you to do sort of a hunt. So here's one that doesn't really show a lot of, it shows some epidermal hyperplasia here. Shows some crusting, shows some granulation tissue, and then we look down at the bottom. Yeah, somebody recognized this as something that doesn't belong here. So what is that thing? Okay. So here's the granulation tissue, and then you got this. And so the board might throw something like this on here and expect you to recognize this, the foreign body. So yes, this is a splinter. Why is it a splinter? Because this is plant material. These are all the little plant cells, xylem and phloem and all that kind of good stuff we learned about in botany when we took things in college. So this is a splinter, and it doesn't have much inflammation here. It's just kind of sitting down there in the bottom of the skin here. Sometimes you get these things, they get a lot of suppurative granulomatous inflammation in there. They get transepidermally eliminated into a little epithelial channel. And then sometimes you look in here, and sometimes you see organisms inside here. So what kind of organisms do you often see in the middle of a splinter? Commonly seen in the middle of a splinter. Good, dematiaceous fungi. And it doesn't mean that the person's got, you know, pseudo-cyst or chromomycosis or any of those kind of things. It just means that it happens to be the plant fungus, the soil fungus, that got transplanted into the patient when they got their splinter. I mean, there was a dermatologist, a friend of mine here in town a few years ago. He had a splinter, and he took it out, and he sent it to the lab, and they said he had pseudo-cyst associated with his splinter, which is garbage. He didn't have that. So to realize that you don't have a pathologic disease, it's just the fungus gets transplanted in there. And unless you're super immunocompromised, that stuff doesn't grow. It doesn't, your body prevents it from growing. So it's not a real pathologic disorder. So this poor guy's got a splinter sticking out of his hand there. So this was a foreign body reaction to a splinter. Now, they might show you that and say, like a multiple choice, they might say suture reaction. No, it's not that. Glass, silica. No, it's not that. They might say reaction to filler. No, it's not that. So this, you can see, it is a plant material, because it's got the little cells in there. So just, you know, they might ask you to differentiate it from something else. Okay. This was an interesting case and one that you might encounter on occasion, both clinically and histologically. Shave biopsy, neoplastic process. Where's the neoplasm situated primarily? So I encourage you, when you're doing differential diagnosis and grand rounds and things like this, to always ask yourself, where is the pathology located? So if I had a biopsy of this, what am I going to see? Kind of separates the dermatologist from the non-dermatologist in the world. They don't know anything about pathology. So if you get an internist that takes a few skin biopsies, they know zero about pathology, nothing, less than nothing. You know a lot. So you can figure out in your mind where you think pathology is going on here. So here, if it's a neoplasm, is it in the dermis? No, there's nothing in the dermis. So it's going to be in the epidermis. An epidermal, mostly neoplastic process. So what are some of the epidermal, mostly neoplasms that we know? Well, we know things like seborrheic keratosis, actinic keratosis, squamous cell carcinoma in situ, maybe hydroid acanthoma simplex, poroma. Yeah, Bowen's disease, squamous cell carcinoma in situ. Now, a lot of people like to divide those up into different categories. I'm a big lumper. And so to me, I call this Bowen's disease all day long. But there are some subtypes of Bowen's disease, subtypes of Bowen's. So any specific subtype here that you see based on this, what do you think the clinician submitted this to us as? Did he submit it as Bowen's? Most likely not. Yes, good. This is pigmented squamous cell carcinoma in situ. It's possible it could be Bowen papulosis, but it doesn't really have the silhouette or the architecture of a condyloma. This is more of a broad area. And clinically, they thought this was maybe a pigmented SK or maybe a melanoma. Yes, they thought this was a pigmented lesion. They shaved it, and it wasn't pigmented lesion. And so it's probably also not Bowen papulosis because there's sun-damaged skin here. So unless the patient really loved tanning booths or was a nudist or something, he got sun damage, and probably not condylomatous HPV-induced pigmented squamous carcinoma in situ, but those do look pigmented. So you're right. And they're often submitted also as pigmented lesions from the groin area, and they're very commonly pigmented. So this is pigmented Bowen's. There are some other types of Bowen's than condyloma, than Bowen papulosis, and pigmented squamous carcinoma in situ or Bowen's disease. What are a couple of other forms of squamous cell carcinoma in situ that you need to know about? What if the cells look very large? They're present throughout the epidermis. What kind of Bowen's disease is that? It's pagetoid. Good. You can simulate Paget's disease. And then you can get like acantholytic cases of Bowen's disease. You know, there's several different forms, but the ones we really get most concerned about are pigmented and the pagetoid type. So this is what these often look like. And these are commonly seen in dark-skinned individuals. So if you see an African-American, for example, and they get squamous cell carcinoma in situ, it often looks like this. They often look like like pigmented squamous cell carcinoma in situ in those situations. So this was you know, basically just a variant that looks histologically pigmented, and they often get confused with melanoma and other things like that because they're pigmented. Okay, punch biopsy. We talked about this a few weeks ago, so this should hopefully a good review for you. It shows a neoplastic process or possibly a malformative process. It's got a big dilated follicular ostium here. We've got these proliferation of these follicular structures, kind of quasi-radiating from a central area here. We've got a cyst here. We've got some maybe calcification even beginning to form a little bone over in this area. We've got a couple areas of miniaturized inferior portions of follicles here. Then we've got some other areas that are not quite as primitive as these areas, and it's got a cyst-like structure. So remember, when we think about the cyst with things that radiate off of it, we think about, you know, maybe about 4 or 5 different things. So if there's small little miniaturized follicles, like little baby hair follicles coming off like a Ferris wheel, we think of what? With a little clear hair shaft in the middle of it, what looks like a tuft of wool, you think of trichofolliculoma. What if it's got the same sort of architecture, but got these more bulbous aggregations? What do we think of there? Good, pilar sheath acanthoma. And it's kind of a cruddy name. Pilar sheath, is it really a sheath? I don't know. It is acanthotic, so yeah, an acanthoma, which is basically means kind of a benign tumor. But think of it as a radiating tumor. You kind of got these things that if you look at one of these things kind of individually on its own, you just went to high magnification of one of these things, it looks a little bit like a trichomoma. So think of it as multiple little mini trichomomas radiating sort of like a trichofolliculoma. So trichofolliculoma is maybe the most primitive, a little bit more advanced. If you get lots of cysts, think of a trichoadenoma in a way. So they're all sort of semi-related. If you get one lesion that kind of have these sort of look like they're not really forming well-defined inferior portions of follicles, just kind of little acanthotic areas with sort of quasi, like mantle areas. Think of the dilated pore of Weiner. So they're all kind of related to one another. They're all related. So this is a pilar sheath acanthoma. Nobody ever diagnoses these right clinically. They look like a little cyst when they get sent in. So it's just another benign adnexal neoplasm. So just recall the general criteria for this. Yeah, you can think of it as a dilated pore of Weiner on steroids is a way to think about that. Okay, low magnification, high power mind. Hopefully everybody got this. It's a gimme. Yes, scabies. Good, scabies. And I don't know, they showed us a molluscum on my board, so they might show you a scabies, something that's obvious here. They might, this looks like it's kind of sitting close to a follicle, so they might say Demodex, but this is not a demodectic mite. This is a pretty classic form of that. So the answer to the other one, they might ask you to differentiate a dilated pore from Weiner from pilar sheath acanthoma, because the pilar sheath acanthoma's got lots more of those acanthotic trichomoma-like areas than a dilated pore, which is basically a larger. Think of that one as more cyst, less epithelium. Acanthoma, more epithelium, less cyst, if you will, and more proliferation there. So they might, but I don't know. It's kind of boring and probably not. But they could show you this, and they might ask you something along what's the treatment of it, or something like that. So this is a classic example of scabies. Hopefully everybody got this right, and hopefully nobody missed the answer. What they would very well likely do if they were to show you this is make it a multiple choice and throw in some other things there. So if you're writing the exam, what might you put on there to try to trip up your colleagues? So put on your malevolent, sadistic hat and think of 3 or 4 things that if you wanted to trip up your neighbor, what would you put down there? Yeah, you could put tick. Chungiasis would be a good one, because that lives in the dermis and has got a little flea. So good, tick would be good. Chungiasis would be good. What else? What else might you put on there? Yeah, Demodex. That lives in a follicle. It doesn't look like this at all. What else would you put on there? I can think of at least 1 or 2 others. What's closer to this? The Demodex is in the mite family. You put lice. That'd be a good one to put on there. How about a non-scabetic mite? Calyatella, something like that. And why is it not that? Why is it not that from this picture alone? There's a good reason. What are we looking at here? What's this actual structure right here where this little lady is living? And she is a mommy, right? So it's a female. So what is this thing? Clinically, what does this look like? Nobody knows? Yeah, it's a burrow. There's the burrow. Sometimes all we see is this with no mite, and we still make the diagnosis. So do the non-scabetic mites form these in people? Does the trombiculid mite So what's that cause? What's the other name for trombiculosis? You go out into the wood in the grassy field, romping around there with no shoes on, in a spring day or early summer day, and come back with all these little bug bites, these red bumps. What do you call those? Chiggers, trombiculid mite. Do they burrow into your skin like scabies? Nobody knows. Well, the answer is no, they don't. Yeah, good. They come this way and they go off of you, or they might grab onto your hair shaft for a few minutes or whatever, but they bite and leave. They don't. These things live in your body, so they're growing, they're hatching eggs. They like your body. They're living. Scirocoptes scabies var humanus. It's basically a variant that's adapted to us. What about if you have a doggy that has scabies and you get the scabies mites from your pup? Do those burrow into your skin like this? No, they don't either. They get on your skin and they can cause a dermatitis on your body, but they burrow into the doggy's skin, but they don't burrow into your skin. So basically, they cause a dermatitis if your dog has scabies, but that's mange. But you don't get the burrows because it's not adapted to you. So this thing is adapted. It's got a synergistic, a nice a symbiotic relationship with you and the way that it lives in your skin. Okay, we've got a couple more here. Shave biopsy, superficial perivascular dermatitis, lots of dark pigmented stuff down here. And what is that dark pigmented stuff? Which you do need to know how to distinguish between these various pigments in the skin. Okay, so what pigment is this here? Now you know what it is. We should know what it is from here. So the differential diagnosis is melanin, hemosiderin, carbon, silver, other drug-related pigments. So this is dark brown. It's not golden brown. Good, it's melanin. And if you're on the exam, unfortunately, I guess with digital, we don't have the ability to do this, but if we're looking at a microscope, we can crank down the substage condenser, and if it's refractile, it's hemosiderin. If it's not refractile, it's melanin. So here it's melanin, and you've got hyperpigmentation of the basal cell layer, and you got melanin in the dermis. So what's the diagnosis? What's the diagnosis? Well, not minocycline, because minocycline is kind of slightly, it's blackish and grayish. It's comprised of melanin plus iron and plus the drug, okay? This could be EDP. It's post-inflammatory pigmentary alteration, okay? Post-inflammatory pigmentary alteration happens to be EDP, but can we tell that from here? No. No, all we can say is post-inflammatory pigmentary alteration. Could be burnout lichen planus, EDP, could have had a fixed drug rush went away, could have erythromelalgia that went away. All we can say from the biopsy is post-inflammatory. But this time it happened to be this. And so, no, you can't tell it from lichen planus pigmentosis. No, basically no. Usually denser, deeper, but no. They're not going to ask you for that because it's not fair. Because that can look exactly like this in a very late burnout stage. Usually if it's pretty early after the LP goes away, it's a denser band like infiltrated melanophages, but that's not a fair question, and they would not ask you that. So just make sure that you understand the differential diagnosis of the different types of pigmentations. So minocycline, you do a Fontana-Masson stain and a Pearl stain for iron, and they're both positive. This would only be positive for Fontana-Masson stain. No, I think I'm a lumper. I think they're all related. I'm not sure about every case of EDP being related to LP. Some people think they are. I'm not so sure that that's always the case, but some maybe. Okay, last case, another one that presumably, hopefully you got this right pretty quickly. So we got an enucleation biopsy because somebody thought this was a cyst. They took a little incision over it, and out popped this lesion. That means it's benign. And we've got is it an epithelial or non-epithelial? Well, it's got epithelium in here. What kind of epithelium? It's got ducts all over the place. Good. And higher magnification, you've got cartilage once again. We saw cartilage before. Somebody says mixed tumor. That's good, and that's what this is. A mixed tumor or chondroid syringoma, which is the same thing, same answer. It's just another name for it. That's a good answer because it's chondroid, and it looks like a syringoma over here. So excellent. And these are almost always benign. Now there is a lesion in the parotid salivary gland that looks different. Somebody asked a question before from before. So if they're both positive, consider minocycline. Yeah, if you get a positive fontanella and a pearls, that's what we do to determine that. So yes, that would mean that. If you only get fontanella, it militates against minocycline. But anyway, back to this one. Yeah, this is also seen in the parotid gland. And what's it called when it's in the parotid gland? It can still be a mixed tumor, but we also refer to it as pleomorphic adenoma. Okay, so it's a salivary tumor also, and sometimes those lesions can have a large number of myoepithelial cells with that. So they can look exactly like a mixed tumor of the skin, but they're in the parotid gland. So that's basically just something to remember, that you can get a similar lesion in a mucous membrane location. So good. This was a mixed tumor of the skin. So they could, this would be a good example for what they would show you to board. This is a classic case. They want to know that you know your adnexal tumors. It's pretty easy. So they would show you this and probably wouldn't have a lot of fancy questions about this. They just want to say, do the guys know what this is clinically? This is probably not what they look like most of the time. They're usually sub-epidermal. They look like a cyst. They're often bluish, by the way, and these are not painful. Okay. Hope you guys enjoyed the session. We'll do another one next Friday. And Rand just walked into the room here, so we're going to post that on sometime next week, and we'll get you guys ready for your boards. Have a good weekend.